Thank you guys all very much for coming. We really appreciate your time. Do you guys know if other people are planning on coming, or are they just enjoying the nice weather today? Nice weather, alright. So my name is Stephanie, I'm the president of the Heart Society, I'm the 5th year, and this is the Heart Society Secretary Christian. So we'll be going through the basics of the ECGs. So are you guys all Imperial 3rd years? Is anybody non-Imperial student? Okay, where are you guys from?
St. Louis.
Alright, wonderful. Anybody from any other medical schools? Okay, good. Anyone else? Okay. Alright, so yeah, if you guys want to, just for our own feedback, for our own portfolios, because as much as we like to teach just, out of the goodness of our hearts, it also does help for us for our portfolios. We have something we can show future residency directors. So if you wouldn't mind going to that website, code vote, and using that code, and we'll just have 2 questions at the beginning, and then 2 questions at the end to show if you guys learned anything. So that would be very, very helpful for us if you were to do that. So we'll give you guys a few minutes. I'm sure your exams are coming up fairly soon, so we'll try to be relatively concise. But what we'll do is we'll go through a little bit about the axis, because that does come up a lot, especially at Imperial, as well as all the main ECGs you could be asked or expected to know. And we'll go through it systematically so that no matter what comes up, you will be prepared for OSCEs. If you follow this method, you won't fail your OSCE station if you have an ECG. So, and then afterwards, for those of you who are still keen, we have several heart members with a whole bunch of packets. We have several ECGs, so if you guys want to get into small groups. We have very, very friendly committee members ready to go through them with you if you guys can practice presenting. And then as well as get some feedback on those presentations. And then for those of you who like worksheets or handouts, there is one on our ICSM Heart Facebook page if you guys would like to go through that when you're going through the lecture. If not, that's fine too. It's whatever helps you do best.
Can we get one more vote? Anyone?
Yeah.
Yes.
Thank you.
Good stuff.
So for those of you who are just coming in, we're just doing this for feedback, just so we can make sure that you guys are learning and that this tutorial is actually helpful. So we'll do this at the beginning and then at the end. So if you wouldn't mind going to that website above and telling us basically how confident you feel that this is going to be wonderful and very helpful for us.
Okay, so to start off with the ECG, we're just going to talk about the electrical pathway for a second. So, first of all, you have the signation alert here, the intrinsic pacemaker of the heart. It has a it depolarizes spontaneously and then conducts to the AV node via 3 internodal fibers, which you can see here, as well as conducting through the Bachmann's bundle into the left atrium. Okay? So then it goes to the AV node. There is a delay at the AV node to allow for ventricular filling. Does anyone know what mechanism causes the delay in the AV node? Or what properties of the AV node? Anyone? So the AV node has a particularly small diameter. It has a complex arrangement of myocytes. The sodium channels are poorly expressed, and there is poor electrical coupling in between cells, so the gap junctions aren't very well organized in between the cells. So once we're through the AV node, we go down the bundle of His and then into the bundle branches, the left one and the right one. Following that, you have the Purkinje fibers. They're very fast conducting fibers, which go down to the apex and then back up to the base of the heart, which you can see here. So, as you can already see on that slide, the SA node fires between 60 and 100 times per minute. And that is also, the range of the normal heart rate. But as you go down the heart, the different parts of the heart have a decreasing intrinsic firing rate. So the AV node fires at 40 to 60 and ventricles at 20 to 40 beats per minute. However, they're activated by the SA node before they kind of depolarize within their intrinsic rate, so that the overall rate of the heart is 60 to 100 beats per minute. So the different parts, so the SA node, the internodal fibers, the ventricles and the Purkinje fibers, they conduct at different speeds. Which part is the part which conducts most slowly? Anyone raise your hand? Otherwise I'm going to pick on people.
Or schools. We can all the different schools against each other.
Well, so I think those are the other London schools over there. Someone from that part. Tell me, which is the slowest conducting part? Of the electrical pathway of the heart is the SA node, the internodal fibers, the AV node, the fibers down here, or the Purkinje fibers going up. So actually it's the AV node, because the AV node conducts at 0.05 meters per second. The fastest conducting part is the Purkinje fibers, okay, at 2.2 meters per second. The atria are surprisingly fast as well. The internodal fibers conduct at 1.1 meters per second, and the ventricles are they're faster than the AV node, but slower than the atria, so conduct at 0.3 meters per second. So I'm sure you're all familiar with this diagram, but for completeness, we're just going to go through it. This is the Eichhorn triangle. It gives you a coronal view, and it basically shows you the arrangement of the limb electrodes and the limb leads. The electrodes, they're there to measure the potential, okay? And they're attached to your right arm, left foot, and your right foot is the ground electrode. It doesn't actually get any signal. So the electrodes, for example, the ones on your arms, or on your wrists actually, it doesn't matter where on your arms they are. It's just important that they're parallel. So for example, if you have a patient with like a really bad tremor, we can try to put the electrodes up here. So the electrodes are different to the leads. Leads are electrical views of the heart. Okay, it's an important difference. A lead is not an electrode. And you have 3 bipolar leads, which are lead 1, 2, and 3. And they're bipolar because you have 2 electrodes giving a signal for those leads. So, for example, lead 1 compares the signal from those two electrodes. Lead 2, those two, lead 3, those two. And always remember that lead 3 is on this side, because if you look at a clock, the 3 o'clock is always on this side as well. And so, if there is electrical depolarization in the heart, going along the line of the lead, then as long as this wave of depolarization is within 90 degrees of the direction of the lead, the deflection in that particular lead on the ECG will be positive. Okay? We're going to expand on that later, just so you get the principle. And this will give you the P wave and the QRS wave, the QRS complex. But as you notice, we have 4 limp electrodes, but actually the limp electrodes, they give you 6 leads. So additionally, you have 3 unipolar augmented leads. And those are the AVR, AVL, and AVF. And you can easily remember where they go, because the AVL goes to the left side, the AVR to the right, and the AVF to the foot. And they are unipolar because they measure the potential from one single electrode and then compare this to a combination of all the other electrodes. Okay? So that's why they're unipolar. So it's good if you understand the previous slide, but this one is essential. So I really tried to explain this to first years the other day, and they did not understand it really quickly, so I'm going to try to explain it to you guys a bit better. But essentially, this is the hexagonal reference system, and it shows you the directions of the leads as going away from the heart. So imagine the heart is here, okay? And lead 1 is defined to be at 0 degrees. It is the horizontal, okay? Any signal anywhere within 90 degrees, okay, within 90 degrees of lead 1, going into that direction, will give you a positive signal in lead 1. Do you understand that? Any questions? Okay? So everything above that are negative angles, and anything below that are at positive angles. So, a signal going into any direction below 0 degrees, so I mean this area, will give you a positive signal in AVF. Okay? Because if it went into this direction, somewhere up here, then AVF would be negative. But if it goes below 0 degrees, AVF will be positive. Okay? And as you can see on the writing beneath the pictures, the normal cardiac axis is between minus 30, so not 0, but minus 30 degrees to 90 degrees. How do you remember which angles the leads go in? So I always remember that lead 1, 2, and 3. 2 and 3 kind of like, if you put 2 cards together, like this, you have 2 and 3, and then lead 1 goes on top. It's like a house of cards, you know? And then if you think of the augmented limp leads, they wonder why. Because AVF like goes up and they kind of form a Y. Do you understand it? So that's my way of remembering it. But feel free to think of anything else. So, as Steph already mentioned, you need to be able to find the QRS axis or the mean frontal plane axis. So just for a second, don't read what is up there. But remember, as I said, an electrical signal in the direction within 90 degrees of a single arrow of the leads in the hexagonal reference system will give you a positive deflection. Okay? The electrode will measure a positive signal, and you'll get the P wave or the QRS. So if lead 1 and 2 are positive, okay? If lead 1 and 2 are positive. So let's think, if lead 1 is positive, the wave of depolarization must be somewhere here. Okay? It can't go here, because if it was here, it would be negative. And if lead 2 is positive, then the signal is going to be at 90 degrees to it on both sides, but it can't be in this area. Okay? It can only be between minus 30 and plus 150 degrees. So if the positive signals of lead 1 and lead 2 overlap, they will only overlap between minus 30 and plus 90 degrees. Do you understand that? That's how the normal axis is, can be derived from leads 1 and 2. If they're positive, you have a normal axis. And to find the exact angle of the mean frontal plane axis, there are two methods. The first method is that you look at the transitioning lead. So, if you have an ECG, can I go to the... So, if you have an ECG, and you look at AVL, that QRS is almost flat. And if this QRS is almost flat, that means that the wave of depolarization, the overall activity, must be at 90 degrees to that particular lead. Okay? Because this one is flat. So a signal at 90 degrees to AVL means that it can kind of be minus 120 or plus 60. And because lead 2 is positive, it'll be plus 60. So the axis of that is plus 60. So basically method 1 is you look at where the QRS is flat and the axis will be at 90 degrees to that, but obviously into the direction where it's more positive and not negative. So you won't have it going into the direction here. So it'll be plus 60 degrees. The second method, I prefer to use that one, is basically you look at the two leads which have the biggest QRS complexes, lead 1 and 2. So you know that the mean frontal plane axis must be between lead 1 and 2. Okay? And if it's between lead 1 and 2, you have it in between 0 degrees and plus 60. And because lead 2 is bigger, I would say it's like 50, 45 degrees. Okay? Do you understand that? Any questions? Yeah?
So is it like, if you've got, so say lead 1 is flat,
Yeah.
is it like a spectrum, if it's flat, it's, so like the more out it goes from 90 degrees, the more up or down it goes?
Yeah, exactly. So if you have anything, if it goes minus 30, it kind of still goes into the direction of lead 1, but not directly. So in terms of vector maths, you'd have a component going along lead 1, okay? But the wave is obviously not as strong going along lead 1, so lead 1 will still be positive, but not as much. And if it's at minus 60 or plus 60, the QRS will still be positive, but even less so. And if it's at minus 90 or plus 90, the QRS will be flat.
Okay, earlier you said that lead was flat on the ECG. Was it flat because it was on the line of the lead?
So we had AVL being flat, right? So let's see where AVL is. AVL is here, okay? So you know that if AVL is flat, the wave of depolarization must be at 90 degrees to AVL. Do you understand that?
Yeah, and what about if it wasn't flat?
Then it would be, so if it was positively, then it would be 90 degrees within AVL to both sides. If it was negative, it would be on the opposite side.
Okay.
Do you understand that?
I think so, yeah.
Okay. So if AVL wasn't flat, then there would be another lead probably that would be pretty flat, and from that you could see which other lead at 90 degrees would give you the direction of the overall depolarization of the heart.
So if AVL is completely flat, does it mean it's going at plus 60?
Yeah, plus 60. It could theoretically go at minus 20, but then you would have a negative signal in V2 because it's going in the opposite direction of V2.
So should you kind of look where it's flat and then work out the 90 degrees one?
Exactly.
And then if it's positive, then it's going to be on the positive side.
Yes.
But if it's negative, then it will be on the negative
Exactly.
side.
Okay, do you kind of understand that? And the other method, as I said, is you simply look at the two biggest QRSs, and it's in between those. The angle must be in between those. Okay? Any other questions? So, and on the slide, it gives you kind of easier algorithm that you could just remember. That if one is negative, it must be the right axis deviation or an extreme right axis deviation. Okay? Because if one is negative, you have the signal going into one of these directions. In this field, it'd be right axis deviation. Up here, it is extreme right axis deviation. Okay? And you can find whether it's just right axis deviation by looking at ABF. But if ABF is also negative, you have to have the signal going up into this corner. Okay? It's going to be extreme right axis deviation. Do you understand that? A hint, always draw out the hexagonal reference system, and you can kind of work it out. Don't worry, we're just going through the basics. It's going to get more interesting. But it's also important to understand how the signal trace comes along. It actually helps you quite a lot with understanding it. So, if you look at what does the P wave show us? Yes, atrial depolarization. But then how come it goes down again? The atrial depolarization is actually the first half of the P wave, okay? And the other half of the P wave is the conduction towards the Bachmann's bundle into the left atrium. So if you imagine a chest electrode on your chest wall, the signal would kind of go away from that chest electrode into the left atrium, so you get a negative signal that brings the ECG trace back down. Okay? Then you have the so QRS. Oh yeah, you've got the answers there. Is the ventricular depolarization. Can someone tell me how the Q wave comes? Why do we have the Q wave?
Depolarization of the interventricular septum.
Exactly, it's the depolarization of the interventricular septum, but the interventricular septum depolarizes from a left to right direction. And this left to right direction isn't really towards the electrode, so you get a negative deflection. And then obviously you get the QRS, depolarization of the ventricles, and get the depolarization of the ventricles towards the apex, so you get a positive signal, and then it goes back up to the base of the heart, so it goes back up, and you get a negative signal going down. Okay? Understand that? Good. And then the T wave. So, can someone explain why the T wave looks the way it looks? Why is ventricular repolarization a positive wave? So, but if it goes away from the apex, why is it positive? That's a good point, because depolarization, when it goes towards an electrode, depolarization, it causes a positive deflection. But if repolarization goes towards an electrode, it causes a negative deflection. Okay? But because repolarization in the ventricles goes away from the electrodes, because you get an outside-in repolarization, you get a positive deflection, okay? So you have to think that the repolarization causes the opposite kind of signal on the electrode, a negative signal, but But because the repolarization then goes away from the electrode, it actually gives you a positive signal on the ECG trace. Okay? And so we have the normal values for waves. First of all, the absolute refractory period is the QRS peak up to the T wave peak. In that period, you cannot depolarize the cell again, and that is a protective mechanism, so the cardiac muscle doesn't tetanize. That's very important. And the relative refractory period, can someone tell me where on the ECG trace we would see the relative refractory period? So we know the absolute refractory period goes from this peak up to this peak. The relative refractory period is the second half of the T wave. Okay, and in that relative refractory period, you can cause depolarization, but only with the bigger than normal stimulus. And then you have the PR interval, which is, on an ECG, it should be 3 to 5 small squares, and because 5 small squares are one large box, it should be smaller than one large box. That is important in heart block, for example, but we're going to discuss that later. The QRS, less than 3 small boxes, and the ST segment here should be isoelectric. So isoelectric means it should be on the, should basically be flat. Not positive or negative. And the T waves should usually be positive.
Alright, does everybody feel relatively comfortable with the QRS axis? I think sometimes it takes some people a bit longer to catch on, especially if likely you don't have a lot of spatial awareness. But if you guys do have trouble with it, come talk to us afterwards or in small group stuff. So what we're going to do now is we're going to go through the main ECGs you should be expected to know. Any one of these, in theory, could come up. And the ones that won't, we'll go through very quickly, just being conscious of time. This one here is normal sinus rhythm. Whenever we say sinus, we mean that it comes from the SA note, the sino-atrial note, sino-atrial, sinus. So when you're looking at this, you need to make sure that whenever you read an ECG, you're going through all the different components, be systematic. When you get to see enough of them, you can start to pattern recognize, but whenever you do not know the diagnosis and when you're in exams, you need to go through every segment. If you go through every segment and report on it, you will likely pass the station. So one thing that is important to know, hopefully you guys have all figured out how to calculate rates. So we do have some of your rate calculations. These ones are if the rhythm is regular. So you only use 1,500 divided by the number of small boxes if the rhythm is regular. What do we do if the rhythm is irregular? Imperial. Sorry?
Cancel on the bottom.
Exactly. And then we multiply by?
6.
Yes. Why?
Because there's 10 seconds.
Yeah, this is a 10-second strip. So from the beginning to the end, that is 10 seconds. So if we count the total number, multiply by 6, that will get you the rate, and that's what you use is irregular. In exam situations, when you're kind of panicking and you're like, oh, 1,500 divided by whatever, you don't really want to do big math, just do that. That is a very, very quick way to do it. So then going through, you do everything systematically. Whenever you're presenting anything, you talk about the patient first. This is patient so-and-so, age whatever, date of birth, whatever, presenting with such and such symptoms. And then the second thing you want to do is look at the quality of the tracing. So this applies for pretty much any medical test, chest x-rays, ECGs. So we want to make sure that we can see all the segments very well, if there's not a lot of artifacts, that we put the leads on in the correct order, and that it's calibrated correctly and take note of the speed. How do we know if it's calibrated correctly? Because this is something at least Imperial expects you to comment on.
Would it say it on the ECG?
It will say the paper speed on the ECG.
25.
Yep, exactly. That is the typical speed, and normally that shouldn't change unless you go and alter these settings on the ECG machine, which most people don't do. To know that it's calibrated correctly, that is what this box here is for. So it should be 10 small squares of height. If that is correct, then you know it's calibrated correctly. So now that we know we have a good quality ECG, and I have not given you any bad quality ECGs just to make it easy, we want to comment on the rates and regularity. We talked about rates. In terms of regularity, what are we looking for? Simply.
The gap between QRS and OS.
Yep, exactly. So we're looking if it's regular or irregular. And so when looking at this, we think this is regular or irregular? Regular, exactly. And most people have a very, very, very small irregularity just related to differences in sympathetic and parasympathetic tone. However, by and large, it should be quite regular. So then what do we have next? P waves. What are we looking for in the P waves?
If present.
Yep, if they're present. What else are we looking for? Okay, so the size and morphology. Anything else?
Absent.
Pardon? Okay. One of the things I always look for is that there's a P wave for every QRS and a QRS for every P wave. That's important. And also that they're small, they're regular, that they look generally normal, and that by and large they're positive. It's important that they're positive in leads 2, 3, and AVF. Those are your inferior leads, and that means it's more likely to be sinus rhythm. Because if you have something coming from somewhere else in the atria, those look different. So that's our P waves. Are we all good so far? Any questions, comments? So if the P waves are negative in the inferior leads, it's not sinus. That is not something you would probably be expected to know in third year or for OSCEs, but for real life, you might want to consider that. So then we look at the PR interval. So as Christian was saying, 3 to 5 small boxes, so less than 1 large box. And that is important in heart block. Q waves. Do we always have Q waves? No. Does anybody know what a pathological Q wave is? So if it's broad? Yeah, okay, so if you have really large Q waves, that's problematic. You might be thinking they're having a transmural infarct, maybe they've had one in the past. So typically I look and make sure that the Q waves are less than 1/4 to 1/3 the height of the R wave. So if they're larger than that, you might be concerned. Until then, if they're small, we're not really going to worry about them for now. Alright, so then we have the QRS complex. So we're making sure that it's skinny. Yep. Pathological Q wave is that they're quite large. So if they're about 1/4 to 1/3 the height of the R wave, then you might be concerned for an infarct. So then our R waves, we're just making sure they're nice and skinny. Generally, this is not an absolute rule, but generally if they're skinny, they're coming from the atria. If they're wide, it's either ventricular or it is atrial with aberrancy. What I mean by aberrancy is that there's either an accessory pathway or bundle branch block. Is that okay so far?
Sorry, can you repeat that? If they're not skinny, they're not.
So if they're wide, then we might be thinking either they're coming from the ventricles or they're coming from the atria, but there's something wrong. There's an accessory pathway like in WPW or ventricular pre-excitation or bundle branch block. Everybody happy? Okay.
Aren't the QRS supposed to come from, isn't it?
Right.
I thought QRS was kind of for the ventricles.
Yes, exactly. So it means if the ventricles have been activated by the atria, so if it follows a normal pattern of activation, SA node, AV node, ventricles, then the QRS will be steady. Is that okay? Okay. All right, so then we're going to look at the ST segment. As Christian was saying, it should return to baseline. We'll go through some abnormalities later. Then we have the T wave. Comment on that. T wave can often be inverted in V1, and it should be inverted in AVR. There's a lot of benign abnormalities where it's inverted, but we'll get to that later. Comments on the QTC interval. We don't typically use QT interval anymore. Why not? Pardon? Exactly, it's rate dependent. So you want to make sure you correct for the rate. And often that is on the ECG. If you guys want to know more about that, you can talk to me later. And then you're going to summarize. You're going to say, what is the overall rhythm and diagnosis? So when you present, you're going to present all of everything we just talked through, then say, in summary, this is normal sinus rhythm. Is everybody happy with this one? Okay, so we're going to try to be relatively interactive with these next ones. Alright, so we're going to go through this step by step because I want to get this hammered into your guys' brain, but we'll try and be relatively snappy because I'm sure you guys have lots of revision to do. Okay, so we have this patient. Okay, we're just going to go through it systematically. Is the rhythm regular or irregular? Regular. Okay, how is the rate? I hear some people say tachy. Does everybody agree? Anybody disagree? Okay, yep, the rate is quite quick. I mean, you can multiply 1,500 by the small boxes, otherwise you can count about 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19 times 6 is over 100. So we know this isn't tachycardia because the rate is over 100. How about the axis? Exactly. We think the axis is normal because 1 and 2 are positive. And remember, when we're doing the axis, we're just looking at the limb leads. Leads 1, 2, 3, ABR, ABL, ABF. We do not use the precordial or chest leads, i.e. V1 and V6 for the axis. That is something I see some medical students doing. Don't do it. Just use the limb leads there on the left. Yet the axis is normal. Alright, so you can go on to some of the fun. Oh, and is the quality okay? Forgot to ask. I always say yes when I ask that question. Okay, and so how are our P waves? Is there a P wave for every QRS and a QRS for every P wave? Yep, fine. Our P wave is nice and small. Okay, how's our PR interval? Yeah, less than 1 large box, we're fine. Any giant Q waves? No. How are the QRS complexes? Are they nice and skinny, not horrendously tall? Yeah. How about the ST segment? Does that all return to baseline? Yep, more or less. Any inverted T waves? Exactly. They're inverted in ABR, which is normal, we expect them to be, and they're inverted in V1, which is also normal, or can be often a normal variant. So therefore, what are we going to call this? Sinus tachycardia. We can say it's sinus because we have nice normal P waves. P wave for every QRS, QRS for every P wave. They're positive in your inferior leads. So we know it's a sinus and tachycardia. No other problems.
So before we go on, one question. Can someone tell me where atrial repolarization is seen on the ECG trace? Yeah, exactly. It's in the QRS. Very good. So the next ECG is, we're not going to go through it step by step, but can someone tell me the obvious abnormality here? Yeah, and why is that? Yeah, basically the rate is less than 60. Okay? When is bradycardia normal in patients? What kind of patients? Sorry? Yes? Athletes? What else? So, I've got down patients on beta blockers.
So often the elderly people are on beta blockers.
Exactly.
Or rate controlling calcium channel blockers.
So, what is this? Anyone say it? See it straight away? So, let's go through this.
So whenever you don't know a diagnosis, if you can't rattle it off right away, go through it step by step.
Also, am I correct in saying that in the OSCEs, they're probably not going to have more than one abnormality?
Correct, probably not. You'll probably just have one main abnormality in each ECG.
Okay, so the rate, what's the rate for this one?
70.
Yeah, it looks normal. Okay? What about the rhythm? So can someone raise their hand and tell me something about the rhythm?
Oriole? Irregularly irregular? Or regularly irregular? Trick question. Is this one, sorry, I don't know if you
Well,
So it's regularly irregular because this one's slightly difficult initially when you're first learning. You will see this very commonly in clinical practice. It probably will not come up in OSCEs. It gradually speeds up and slows down.
so you can see it's speeding up here and slows down here. Okay? This is respiratory sinus arrhythmia. Okay? It's common in patients under 30 years of age, and if it's not related to breathing, it's a non-respiratory sinus arrhythmia. And often, rate speeds up when you breathe in and slows down when you breathe out. Okay? Inspiration increase, expiration, decrease. So inspiration, increase, post, I don't know how you can remember that. But this is still a sinus rhythm, okay? Because you have a P wave for every QRS and a QRS for every P.
And the P waves are normal.
Yeah.
So just a quick sinus review. We've done all of these. We had normal sinus rhythm. That is your normal ECG. Sinus tachycardia. Any tachycardia is over 100 beats a minute. Sinus bradycardia, everything normal except the rate is under 60. And sinus arrhythmia. Any questions on those?
Sorry, can you go back to the last one? Is all of these going to be 3 normal or are those under deep?
Those are normal.
Are they deeper than the ones before? Or are they this time?
So sometimes, are you talking about the heights of the R wave or the
The deepest, yes.
Yeah, so sometimes that really does depend on the patient. So it's a lot of different factors. Men tend to have higher voltage than women. Younger people have higher voltage than older people. It can relate to chest wall thickness and some medical conditions. So for a lot of you, if you guys have done ECGs on each other, you'll notice a lot of you have quite high voltage, which might not be the case when you're working in the wards and care of the elderly where they have smaller QRS voltages. So a lot of it depends on that, unless they have pathological conditions like LVH, which we'll get to.
So how abnormal is it? How do you know an SO is abnormal or normal?
So there are several different criteria for like LVH, for example, and we'll get to those. So basically, whenever the voltage really jumps out at you, especially after you've seen enough ECGs, then you can say, okay, maybe that's abnormal. This is probably not that abnormal. This is probably a relatively youngish, healthy-ish patient.
Alright, thanks.
Any
So
other?
also, there are other conditions like one of the bamboo branch blocks, but there are also deep S waves, but they are also broad. Okay, so this one is not particularly; it's still 3 small squares.
Okay. If anybody can spot any major abnormalities, just shout them out. Otherwise, we'll go through it step by step.
Okay.
Okay, yep, so this is a tachycardia. Okay, so you do all your normal intro stuff, patient, quality, calibration, everything else like that. Then we actually read the ECG, axis is normal because
Leads 1 and 2 are positive.
leads 1 and 2 are positive, exactly. Do you see any P waves? Who says yes, you can see P waves? Raise your hand. Okay, who says no, you cannot see P waves? Okay, and everybody else is undecided. Okay, so basically you can only see one real wave in between each of the complexes. Whenever you can see only one, it's typically going to be the T wave, especially if it's this quick. So basically, this is going so quick that you cannot see the P waves. So can we say it's sinus? No, so we don't know what's going on with the P waves if there are P waves. We have no idea. So whenever rates get really, really quick like this, a lot of times this is what people refer to as SVT. Have you all heard that term? Don't use it. Use narrow complex tachycardia instead. I'll tell you why. One, you can never ever be wrong if you use narrow complex tachycardia versus wide complex tachycardia. You simply won't be wrong. Electrophysiologists also prefer this terminology because some narrow complex tachycardias are their pathways in the ventricle, so it's not technically accurate. So if you ever have a very, very fast, regular rhythm and you want to say it's SVT, don't say SVT, say NCT or narrow complex tachycardia. And just for fun, can anybody tell me 2 different types of NCT or narrow complex tachycardia subtypes? Okay, Wolff Parkinson White, which is a part of AVRT, and what's the other major one? AVNRT. Excellent. Okay, so what do we have going on here? Okay, so speaking of WPW, is everybody confident seeing that this one is WPW? Okay, we're going to go through it step by step. We're going to go back to our step-by-step algorithm, which you guys can use for OSCEs anyway. Quality is fine, patient, name, info, everything else like that. P waves. We have P waves for every QRS and a QRS for every P wave. Who says yes? Hands up. Okay, who says no? Good. The yeses have it. Our P waves are fine. How about the PR interval? Is it between 3 and 5 small boxes? I'm getting a few no's. It's too short. Exactly. So we have a very short PR interval. Right after the P wave, we're going straight on to the QRS. So there's effectively no PR interval. What about the QRSs? What do we think about those? They're a bit broader. Can anyone tell me why they're a bit broader, or what's the main abnormality there? Is the entire thing broad? Exactly. So what we have here, we have a short PR interval, and then we have what's called a delta wave. So almost immediately after the P wave, we have that slurring. We have that little slurring right into the QRS. Normally it just goes straight up. We have that slurring. That slurring is called a delta wave. So what we have here is an accessory pathway. Some textbooks call it the bundle of Kent. Use the term accessory pathway instead. It's a preferred term among electrophysiologists. So short PR and the slurred upstroke is WPW or ventricular pre-excitation. Same band, different path. Any questions about that? Anybody super curious to know why it looks like that? Or you guys just kind of want to get on and learn all the ECGs? Pardon? Yep, so basically, usually over the AV node and all that, conduction is quite slow. So because you're not really going through that AV node, you're having that accessory pathway, which is quite quick. That is the cause of a shortened PR interval. And then because you have to activate your normal pathway from laterally rather than through the normal pathway, that is the cause of the slurred upstroke. Does that make sense?
Is this an APRT?
Yes, it's a type of AVRT.
Yes, just also for our live stream, by WPW we mean Wolf Parkinson White, and by LVH left ventricular hypertrophy. Let's go on to the next one. So I'm going to pick on some of them.
So I have a quick question.
Yeah.
For the AVRT, what does that stand for again?
AV nodal reciprocating tachycardia.
Re-entrance tachycardia.
Yeah, there we go.
Right.
I don't use the whole term anymore.
AV re-entrance tachycardia, I would say.
And why is it re-entry?
Sorry, the re-entry is AVNRT.
Yeah.
AV nodal re-entry tachycardia is AVNRT. AVRT is AV nodal. We'll look it up. I also read the full term, I just use the abbreviations.
Yeah. But I think if it's re-entrant, it refers to the electrical, to disturbed electrical pathways which go around in a circle in the heart. So, don't put me in that. Anyway, so for the OSCEs, you need to be able to present it step by step. If you want to buy yourself some time, say first of all that it's a normal axis and give yourself a bit of time, be slow, and then it gives you time to think. Anyway, any volunteer to, yeah? Exactly, start off by, you say the patient name, date of birth, ID, time and date when this was taken, the symptoms, and then the paper speed and voltage, okay? And then start off with the rate. So, how many QRSs can you count? 15. 15 times 6, 90. 90 is normal, so it's not tachy, okay? What's next? Yeah, so the rhythm is, would you say it's sinus? No, it's not sinus. But, so it's slightly weird, right, the rhythm? And because you have like a constant time interval, because it's like regularly weird, it's regular, irregular rhythm.
It's just regular. Sorry, this is regular because the complex is the R interval is regular.
Yeah.
It's regular, but it's not sinus because you've got more than one.
Right, there's something weird going on with our atrial baseline. Does everybody see that?
So next we would go on to the P wave, right? Yeah. Okay, see that.
So it looks like multiple waves.
Yes, how many P waves would you say are there? Sorry?
She said
2 to 1. So actually, if you count, you can see, at the end of this QRS, you have like the P wave already?
These actually we don't even call P waves, we call these F waves.
Yeah.
Because because they're not from the sinoatrial node. They don't look normal.
So you have 1, 2, 3, 4. So this would be, and the sawtooth baseline is a characteristic feature of atrial flutter. So you have atrial flutter with 4 to 1 conduction block. Does everyone understand why?
Sorry, where the 4?
So,
Usually two.
okay, lead 2. So you have the one here, the one here, the one here, and then one here.
Oh, so it would be the dips, not the peaks.
So,
So basically, what you're getting is some of these F waves are slurring onto the QRS complexes. So right after you come off the QRS, you'll notice a little bump, and that's basically that F wave slurring onto the Q wave.
So is there no T wave?
So the T waves you can't see. In theory, there are T waves, but we can't really see them all that well because the flutter waves are just so obvious and abnormal that they're covering up any T waves. They do exist, we just can't see them.
okay, so the AV node prevents the flutter waves to be conducted. And the ventricular rhythm is regular, but it can cause tachycardias, okay? So the rate is slightly fast anyway, but it's not tachycardia yet. And it is similar to atrial fibrillation, which we will come on to in a minute. But the flutter here is really quite steady, and it seems to be like marching on, okay? So it's at a steady rate, and it's atrial flutter. And this one, okay, tell me something about the rhythm.
Regularly irregular.
Right, exactly. It's regularly irregular, and you have the 4 waves here, but then 2 here, 4 waves here and 2 here. So if you put a piece of paper beneath that and mark where the P waves were, and you would move it along, you'd have the P waves on exactly the same location on your piece of paper, yeah?
Sorry, in this one and the one previous one, can you comment in on what would you say about the P and PR?
So you say that you can't see the PR, so you can still comment on it saying there are no P waves, however there are F waves in its place. We cannot comment on the PR interval.
Okay. And basically because you have 4 and 2, you can call this a 6 to 2 conduction block, perhaps?
I always prefer the term variable conduction block.
Yeah.
Either should get you points.
Okay? Go on to the next one. Does anyone want to do this step by step? The rate is 84, I think. The rhythm. What can you tell me about the rhythm? At the bottom.
Regularly irregular.
Yes, exactly. It's irregularly irregular. The axis is normal. It's irregularly irregular because it's just kind of random distances in between. Okay? So, the number, if the pulse is irregular, your number one suspicion is atrial fibrillation. And the number one indicator of atrial fibrillation is an irregular ventricular rhythm. So also you have these baseline F waves and pretty much absent P waves. Okay? So this is atrial fibrillation. It increases with age, and there is no effective atrial contraction. So normally, this doesn't cause any problems because the atrial systole only tops up the filling of the ventricle to a small degree. But during exercise, atrial systole takes on a much bigger role, so patients will have problems, particularly during exercise. The stroke risk is increased, as probably most of you know, and whether you give the patient warfarin depends on the score of the CHADS-VASc score. Do you understand atrial fibrillation? Okay. Can someone quickly tell me what this is?
Guys in the back row, what is this?
Yeah.
Yes, what's so special about this AF? So it is a slow AF. I just call it slow AF. Right?
It depends on which country you're from. The Brits tend to call it slow AF, the Americans tend to call it slow ventricular response, or AF with SVR.
And then, for completeness, this is an AF with a rapid ventricular response or a fast AF. Notice here, it is difficult to see the F waves, okay, in some leads. It's quite difficult, but the thing that really tips you off onto AF here is the irregularity of the QRS waves, okay? Anything else?
Are those, sorry,
Yeah?
are those S waves and like, they just look really deep overlap and really just agree overlap? Is that normal?
It can be. I think in this patient it's probably relatively normal. I think they're just kind of blending onto each other for like about a box, a little over a box. When we show you the picture of LVH, or we don't have one of RVH, but we'll show you some pretty extensive R waves, rest waves.
So this one. Let's go through this step by step and you will be able to get onto the diagnosis. What's the rate? Someone shout it out.
75.
Sorry?
75.
Yeah, I think it's roughly about that. It's normal, okay? And the rhythm?
Regular.
Yeah, it's regular. And the axis? Normal?
Yeah.
P wave?
Yeah, there's P waves.
So there is P waves, right? Let's look at the PR interval. What can you tell me about the PR interval? Prolonged. Prolonged PR interval. A consistent lengthening of the PR.
Length, not
Yeah, consistent length of the PR, but it's too long. What would it be?
First degree heart.
Yes.
Are we concerned at all about first degree heart block? Does that worry us at all? Are you going to shock them, give them some drugs? Who's going to shock them? Good.
What was that? The treatment, sorry.
Yeah. So what do we do for first degree heart block? Nothing. We don't care about first degree.
Do you guys so far understand it? It's okay?
To my knowledge. Yeah. Okay. So for this ECG, unless anyone ever wants to shout out a rhythm, we'll go through it step by step. So after your general introduction, is our axis normal? Yes, because
1 and 2 are positive.
1 and 2 are positive. Excellent. Okay, do we have P waves for every QRS and a QRS for every P wave? No. When we say no to that, it is going to be either second or third degree heart block. If you answer that question no, it will be second or third degree heart block. That is important. Okay, so now we're going on to our P wave, our PR intervals. Our PR interval consistent?
No.
No. What's it doing?
Increasing.
Right. What are we going to call this?
Second degree type 1.
Yep, second degree moments 1, or Winky Bach. So basically what's happening here is we have a slightly prolonged PR interval here. It gets longer. And then we have a P wave here and no QRS. We have a drop to QRS. One way I was taught to remember this was lengthen, drop equals Winky Bach. If it works for you, great. It does for me. So just remember that if you have a PR interval that is consistently getting longer, you drop a beat, and then the entire cycle resets. So at this one here, you'll notice that this PR interval is the same as it was initially. And then again, it's longer, drops. Lengthen, drop equals Winky Bach. We all okay with that one? Questions? Okay. All right. Anyone ever want to show up a diagnosis? Okay, we'll go through it. Yeah. All right. Is everybody okay with that? Should we go through this anyway? All right, let's go through it. All right. Why don't we have somebody on this side other than our one responder at the front here? We'll have you guys in the middle here respond. Okay. How is our QRS axis? Is it normal? Yeah, it is normal because lead 1 and lead 2 are positive. Is that okay? Okay, how's our rate? Is our rate fast or slow? Slow. Okay, how is the rhythm? Is the rhythm regular or irregular? Yeah, it's regular. Okay, so we're going to move on to our P wave. So we have a P wave for every QRS and a QRS for every P wave. No, we can't answer that question positively. Therefore, this is either second or third degree heart block. Okay, so now we're deciding which one it is. So, PR interval, are they consistent? The ones that don't have a drop complex are consistent. So we look over at our first one here. It's a fairly normal PR interval. And then we get our wave, we have a P wave here, and nothing, no QRS. And then we have a PR interval that was the same length as the first one. P wave, no QRS. So basically there's a pattern. P wave, QRS, P wave, no QRS. That is how we get to the diagnosis of second degree heart block, Mobitz 2. So you have a fixed ratio of P waves to QRSs. Is that okay for everybody? So when you do have the consistent PR interval, or when you have the PR interval, it is consistent. Lengthen, drop equals Wenke-Bach, that's Mobitz 1. Mobitz 2, you have a fixed ratio of P waves to QRSs, so this is 2 to 1. Because there are 2 P waves for 1 QRS. Are we all okay with that?
So
Ready?
It's not random. I wrote random, not QRS. It's not random.
No, it's not typically random because it's every other P wave.
And can you get different ratios? Would it still be type 2? Maybe it's type 2.
Yep, you can absolutely get different ratios. So you can get 3 to 1, 4 to 1, so typically really, really slow rate would be more symptomatic. But yes, you can absolutely get different ratios, but it's always, there's a pattern to the.
Do you still call it a sinus rhythm, even though the drop to QRS is just...
You have sinus rhythm with second degree heart block. Pardon? This is a 2 to 1 ratio because there's 2 P waves per 1 QRS. Any other questions? Okay. Okay. Anyone want to venture a guess what's going on here? Third degree heart block. This is a pattern to the way we did ECGs, first degree, second degree, now third degree. Makes sense. Okay, so let's go through step by step anyway, just for a little fun. All right, axis, is it normal or abnormal? Normal, because these 1 and 2 are positive. All right, how's our rate? Slow. Exactly. You'll notice that the second and third degree heart blocking rate is often very slow. And that's because we're dropping QRS complexes. Okay? So our rhythm is regular, rate is slow. How are our P waves? Is there a P wave for every QRS and a QRS for every P wave? No. So this is either what? Second or third degree heart block. Excellent. So how are our PR intervals? Exactly. Are there any PR intervals? Not really. So basically what you have going on here is this is third degree or complete heart block. So you have the atria firing, but they have nothing to do with the rate of ventricular firing. Okay? So the atria march out a consistent length. So if you were to look at your P waves, so that P wave is this P wave, and then this one which is blended onto the QRS, and then the next one, those all march out at the exact same rate. So your P to P interval is always constant. But it has no relation to the QRS complexes. The QRSs, those are consistent in rhythm, but have no relation to the preceding P wave. There's absolutely no communication going on there. Does that make sense? Hopefully. Quiet audience. Okay. So is this a happy rhythm? Are we going to do anything about this? Yes. Yes. Some places consider this an emergency rhythm. So I've worked at Mayo Clinic for the last 4 years, last 4 summers, and they consider this an emergency rhythm because it so rapidly degenerates into a cardiac arrest. So you then, like the level of danger, I guess, is related to basically how far along that pacemaker is. So we can see that our QRSs are still fairly skinny. The skinnier complexes tend to be higher up, more proximal in the conduction pathway. Whereas once that pacemaker comes farther and farther down, i.e. the block is lower, it becomes slower and less stable and more likely to degenerate into a cardiac arrest. Okay, so this, if we saw this, you would want to ship somebody up to get a pacemaker, either transcutaneous or a temporary pacemaker pretty quickly. Make sure they're very well monitored. So, heart blocks. These are a huge thing. You need to know them for third year. You absolutely need to know these. These are a must. So, do not overlook these. These very well can easily come up in OSCEs, final exams, not only in third year but beyond as well. So first degree, we have a consistently prolonged PR interval. That PR interval is always the exact same length. Second degree, length and drop equals Winky Bog. Moments 2, we have a fixed ratio of P waves to QRSs. We have the drops to QRSs. And third degree, no communication between the two. And if you have trouble with these, either any of us can help you afterwards. Otherwise, there's all sorts of videos or analogies with broken relationships at home. You know, the husband comes home later every night, so he doesn't come home at all. There's all sorts of that kind of stuff on the internet if it helps. But definitely know these.
You said with first degree you don't treat, third degree you give them a pacemaker. What do you do for the second degree?
So I believe moments 2 is more likely to degenerate. Personally, I would call a cardiologist. That's a student. Yeah, you would definitely want to let somebody know about second degree heart block. Definitely let somebody know and alert somebody higher up.
Right. So, any guess to what this is? Just go through it in your head. Rave rhythm axis, P. Yes, very good. It is a left bundle branch block because, as we said, in V1 particularly, you get a deep and wide S wave. Okay? Left bundle branch block. So you have to just think about it. It makes sense. So the electrical depolarization goes down both the branches. So if the left one is blocked, most of it goes down the right branch, and then the right branch isn't particularly in the direction of V1. Well, anyway, it makes sense. So this is characteristic of left bundle branch block. And it's important to note that ST elevation, have you all seen this? That there is ST elevation? This is normal. It can be normal. Secondary to left bundle branch block. Okay? Remember it.
Is it only for left bundle branch block?
Sorry?
Is the ST elevation only normal for left, or do you
We'll
see
show you in the one after this. So you typically with any of your bundle branch blocks, you do get ST, T-wave abnormalities, and then secondary to the bundle. Imperial at least likes you to know that new onset left bundle can be equated with an MI. So that is a very common exam question. I know I've seen it before. However, in real life, it's maybe not quite as common as you think. I've seen hundreds of left bundles, not a single one of them is having an MI. So keep that in mind. So obviously your history comes into play here. Does anybody see what's going on here? No? Okay, we do have some ST elevation indeed. Anyone see anything else? Pacing spikes. I'm going to show some pacing spikes. So pacemakers often stimulate a left bundle branch block. So whenever you see a left bundle branch block, look before, and you can see that we have pacemakers before both the P wave and the QRS. So this is an AV sequential pacemaker, and when I mean that there's a lead in the atria. We know that because it comes before the P wave, and one before the QRS, so we know that there's a lead in the ventricle as well. So because those are put on the right-hand side, it basically stimulates left bundle branch block because that wave of depolarization has to go from the right to the left, hence the prolonged QRS intervals. And then because it looks like a left bundle, we know that there's going to be secondary ST elevation changes, especially in your anterior leads. So I'm not going to be terribly worried about ST elevation because all of these just look a little funny. Pacemakers everything look a little funny. So this guy's pace. The other thing you can do is, now whenever you have a perfectly regular rhythm, you'd be considering a pacemaker. Remember I said earlier that most of us, even with regular rhythm, have very, very slight irregularities. Pacing is typically exact. That's a pacemaker, just thought you guys should know what it looks like. Unlikely to come up in OSCEs, you will see this in your life, and most people don't know what it is.
Right. So this one, anyone can tell me there's one really distinct feature?
Is this right one?
Why?
Because it is the RSL pattern in V1.
So, exactly. So this is right bundle branch block. It's got a very distinct rabbit ears, they call it. Basically, think about the wave going down both the right and the left, and then it kind of stops in the right bundle. So it drops down again, but then it goes down the left bundle again and goes up. So that gives you the rabbit ears. Because rabbit starts with an R, it's the right bundle branch block. Okay? T-wave inversion, secondary to the bundle, is normal usually. It's usually normal. And so did everyone go through it step by step? If you did, then you can tell me something else.
Left axis deviation.
Exactly. There's left axis deviation here because D2 is negative. This can be normal and doesn't have to be pathological. And also, the right bundle branch block makes the QRS a bit wide. Okay?
So typically the T-waves go in the opposite direction of the terminal deflection of the QRS. So basically just on the T-waves, you should go in the opposite direction. So whenever you see, so you'd be worried actually if those T-waves were positive in, V1, for example. So it is normal to have STT changes. Whenever you see those in a bundle, don't be immediately alarmed.
Sorry, so you get left axis deviation and right bundle branch.
Not in this ECG.
Is that normal?
It could be.
I thought you get right.
Not in this guy.
Yeah. So it could be either.
They don't necessarily always correlate. Okay, who's asking about the voltage? Is that you? What do you think about this one? This is a horrendous voltage. Horrendous voltage. So it's definitely blurring out multiple things. You can't even really see where they start or stop. This is a fairly extreme example of LVH. I don't know whether or not you'll get this on OSCEs, but you should be able to recognize it. There are a hideous number of criteria out there, voltage criteria. A lot of students try to memorize them. I don't personally recommend that because some of the voltage criteria look like this. So the one on the right is a whole bunch of point-based things. I'm not going to memorize that personally. I don't recommend you do either because these criteria are not particularly sensitive. They're relatively specific. They're over 90% specific, but they don't pick up everybody. Typically, you diagnose it on echo instead. What a lot of electrophysiologists do, what I do, is pattern recognition. Once you see enough of these, you'll be able to say, oh my gosh, that's a lot of voltage, and then you might be thinking something's going on. If you absolutely need voltage criteria, if you really want, I think the second one is the easiest to remember. I just remember RAVL SV3, RN AVL, and SV3. That one's even worse on sensitivity. It's like 22%, so it's a bad criteria. But if you're stuck in an exam and need to remember something, that's probably the one to remember. Otherwise, just say it's a lot of voltage, And the other thing to know, what else is going on here? What else are our problems in this ECG? Yeah, we have quite a bit of ST elevation. There are a number of different conditions that can cause ST elevation. It's not just MI, and LVH is one of them. So there's a lot of elevation, especially in V1 to V3. And you also see that we have some T-wave abnormalities. We have some biphasic T-waves over here, a lot of T-wave inversion. A lot of that is secondary to LVH. So that is just something you should be able to recognize. Any questions on LVH? This is just another one that hopefully you should pattern recognize. Anyone know what's going on here?
Is it VF?
Pardon?
Is it VF?
No, it's not VF. Okay, we'll go through this step by step in the ECG. Do we have P waves? No, it's not VT.
Pericarditis?
No, it's not pericarditis. This is hyperkalemia. So this is one you should know. We didn't have it in last year, but we thought we should add it because a lot of people asked us questions on it. So what we have here are some huge T waves. They're symmetrical. That is important. They're called Eiffel Tower T waves. They're very, very tall and they're peaked. So then they are symmetrical. I specifically mentioned twice that they're symmetrical because if you have asymmetrical peaked T waves, that can be a benign variant. I have it. I'm pretty sure I'm not about to die from cardiac arrest. I hope. So your tall tensor T waves, that is your first sign of hyperkalemia. And then after that, you get progressive atrial paralysis. So your P wave widens and flattens, PR interval gets longer, P waves disappear, and then you can get some conduction abnormalities, and eventually they go into cardiac arrest. So hopefully it won't get to that point, but whenever you see this on ECG, you know you should do some blood and measure your potassium.
What's the thing that's tempting that's
So the tall tensor T wave. So I'm especially looking at V3 for example, and those symmetrical tall T waves are quite specific for hyperkalemia. Once you get used to seeing a lot of the different T wave changes, because there's a lot of different things that can give you tall T waves. For example, hyperacute T waves are part of MI, but they look slightly different. Pericarditis, as you mentioned, has a scooped appearance, and then you typically see ST elevation in every single lead. Any questions on this?
Is tentate just in the tall?
Yeah, like if you have it's spiky, it has a peaked top.
Am I right in saying that usually it's also missing absent P waves?
Exactly,
And
after all, the
full
P waves
QRS.
disappear, and then the QRS gets longer. Exactly. Okay. Anyone spot the abnormality here?
Is it inverted T wave?
Inverted T wave, exactly. So, of course, every single time you want to go through this step by step. In the interest of time, somebody kindly pointed out that we have some T wave inversion. Which leads are the T waves inverted in? Anybody?
V3, V5.
Yep, V3 through V6. So, does anybody know what those leads are? Does everybody know how you name the different leads, different areas of the heart?
Can you go through them?
I think I might have a slide on it. Maybe I don't. No, apparently I don't. So your V1 to V2 are septal, V3 to V4 are anterior, V5, V6 are lateral, as well as lead 1 and AVL. 1 and AVL are sometimes called high lateral, and then 2, 3 and AVF are inferior. Okay, so this is some anterolateral ischemia. So whenever you see the symmetrical T wave inversion, or even sometimes biphasic T waves, you want to think of ischemia. And whenever you see any sort of abnormalities, you want to make sure they're in at least 2 leads. Whenever you get them in just 1, it's much less significant than if you get them in 2 contiguous leads, so leads in the same order. So if I just saw them in V1, I'm not going to be concerned terribly. If I see them in V1 to V6, that's much, much, much more significant. And that goes with both T-wave inversion and ST elevation. Is everybody okay with that? T-wave inversion, think angina or ischemia. Okay? Yep, so we have V3 anterior, V4 anterior, and then we have some in V5 and V6 as well. Those are lateral leads. So this is anterolateral ischemia. Any other questions? Okay. Anyone want to shout it out? George's? George's and King's? Oh, the James were together. Exactly, ST elevation. Does everybody see that? Does he have some ST elevation in which leads? Yep, anteroseptal leads. So we have a bit in V1. Often we're most concerned when it's over 1 millimeter, so over one large box. So we have a tiny bit here in V1. Tiny bit here in V1. We have part of it in V2 and V3, and a little bit in V4, and it kind of goes back to normal. You want to give me the diagnosis? MI. So this is a ST elevation MI or STEMI. Okay?
Where is it?
Yeah, so anyone want to tell me where it is? We talked about it being anteroseptal. Anyone know what coronary artery that might be? LAD, left anterior descending. Okay. Abnormality? Yeah, we have some more ST elevation. Exactly. Which leads are these in?
2, 3.
Yeah. I hear people say 2, 3, and ABF. Which leads are those?
Inferior.
Inferior. Okay, and what's going on in V1, 2, and 3? Mostly 2 and 3. Exactly. Well done. This is both an inferior and a posterior infarct. So we can see the inferior infarct because we see the ST elevation in leads 2, 3, and ABF. This is what's called a tombstone sign because the T wave looks like a tombstone. Okay? So we know that there's an inferior infarct. Whenever you see inferior, always look for posterior. There are 2 ways we can identify a posterior infarct on an ECG. Does anybody know what those are? So we talked a little bit about V1 or V2 and V3. We'll get to that in a second. What's our other way?
It's more electrodes.
Yes, wonderful. Puts more electrodes on. So normally it goes to V6, which is over here. You can say V7, 8, and 9 on the back on the posterior side if you really wanted to. Or easier and quicker, which you can use, you can take ECG, flip it around, and then flip it upside down. And you'll notice that V2, V3 look like elevation. So if you see that, then that is a posterior infarct. What?
So it's an ST. It's a semi.
Yes.
So it doesn't look like
Just because we don't have any specific leads on the 12-lead ECG that, for a specific posterior part, so you have to either flip it around upside down in the kind of anteroseptal leads, so that they're posterior infarct. Does anyone know what coronary artery this might be? Sorry? Can't hear you. I'm going deaf. No, it's not the circumflex. Circumflex would give you more of a lateral.
Right coronary artery.
Yes, the right coronary artery. The right coronary typically supplies the inferior side of the heart, and in most people supplies the posterior side of the heart. Okay? This is the right coronary artery blockage. This one will not be on your exams most likely, but you need to know it because all of you will have these. If we were to record every single one of you for 24 hours, every single one of you would have some of these wide bizarre complexes. You will see them, you do need to know what they are. Anyone know? Yes, exactly. So we'll just say for the record that the rest of the ECG is fairly normal. Regular rate is fine. P waves great, variable fine, no pathological Q waves, R waves fine, STT waves fine. So it's just these really wide bizarre complexes. Christian's pointing out both of them now. Whenever you see that wide bizarre complex, that is called a PVC or premature ventricular complex. So basically the ventricle just kind of beats a little bit early. Because it's coming from the ventricles, it's wide. Okay? And if they look the same, we know they're coming from the same area. All of you will have these. They're often caused by stress, caffeine, things like that. So if you ever felt your heart skip a beat, That's exactly what this is. Yes. Yep, so they're either called PVCs, VPCs, or VEs. So VE, ventricular ectopic, PVC, premature ventricular complex, or ventricular premature complex. They're all the same thing. So basically just an ectopic area in the ventricles firing a little bit early. Does that make sense? We're not going to worry about them unless there's a lot of them. Is this something to worry about?
Yeah.
So basically, here in this one, you have more than 3 PVCs in a row. And because it looks fairly normal, like not normal, but I mean, get the picture. It looks the same pattern everywhere, right? You get many PVCs in a row. So this is called the monomorphic ventricular tachycardia. Monomorphic VT. Okay? So basically all look the same. This is probably a medical emergency, and especially if there is no pulse. And this is then one of the shockable rhythms, the VT. Yeah.
So earlier we talked about SVT really should be called NCT, narrow complex tachycardia. You would call this wide complex tachycardia. Note that if you have something coming from the atria, so if you have an atrial rhythm plus aberrancy, i.e. bundle branch block, or an accessory pathway, it will result in a wide complex. So there are several criteria to be able to differentiate these two. I wouldn't expect you to know it at this level, but just for the future, know that there are some criteria that can help you differentiate. And when in doubt, treat as VT.
Sorry, this came up on what got here. I didn't know how to present it. It's like,
Sure.
crazy. How to do it.
Okay, so you start with the normal same stuff. So you'd say, this is patient X, age whatever, date of birth. This is 12-week ECG taken 10 minutes ago in the emergency room. The patient was unconscious and did not have a pulse. The 12-week ECG, we cannot see, the axis appears to be, we can't really read the axis very well. There are no P waves that we can see. We cannot comment on the PR interval because there is no PR interval. The QRS complex is wide and it is consistent. It is monomorphic. We cannot see the T waves, therefore we cannot comment. This is a diagnosis of a wide complex tachycardia, most likely a ventricular tachycardia. So just go through it. Even if you can't see all the waves, comment on each of them individually anyway. And just say you can't comment on what you can't see. Any questions with this? Okay. Is this always dangerous? Is this always an emergency? No, not necessarily. I know some people have been told that SVTs or narrow complex tachycardias are stable and VTs are unstable, but that is not always necessarily the case. You can get people walking around perfectly normally, just like the rest of us who have a VT. The stability of their condition depends on what their underlying condition is like, what's causing this, the size of the heart, and the rate. So this isn't always an emergency. If you see this, though, you probably would want to let somebody know. And obviously, make sure you check their pulse if you're unconscious, and then initiate ACLS protocol. Anybody familiar with this rhythm? Torsades. Exactly. Torsades is long. So basically what we have here, this is a type of polymorphic VT. So remember the last one, they all look exactly the same. Each of these waves look exactly the same as what we call monomorphic. Mono one morphic form, one form. This one is polymorphic, coming from different places. And so you'll notice that it's wide, skinny, wide, skinny, wide, skinny. Some people describe it as like a twisting of streamers, like at children's birthday parties. This is torsades. This is another type of VT.
How do you spell that?
How do I spell it? Torsades space DE space POINTES.
Too quickly.
It's called twisting of the baseline.
Is that one shot?
If it's pulseless, I would shock it.
Is this one you give my
Yes, exactly. So the difference between this and monomorphic VT in terms of treatment is that you would give them IV magnesium.
You give IV what, sorry?
Magnesium. And this can be caused if you have long QT. So you guys might have heard of long QT syndrome, often genetic. And Christian talked about the relative refractory period. So if you get a long QT, you have that slightly longer area of a relative refractory period. If an R wave falls on that, that can precipitate torsades. And that's why people with long QT die. Are you all okay with that? It's RRT phenomenon. So the R wave falls in the T wave.
By R wave, is that a ventricular ectopic?
Yep. So just like your regular R wave here, so one of these falls in the preceding QT interval. Okay, and then what's this?
VF.
VF, ventricular fibrillation. So remember how in atrial fibrillation, the atrial activity was really kind of chaotic and all over the place? This is the ventricular version of that. What are we going to do about this? We're going to care about this? We're going to treat it? Yeah. Is it what type of condition would they be in? Cardiac arrest. Sorry, I don't know if that question made any sense. So you have 4 cardiac arrest rhythms. Pulseless VT. They have to be pulseless. VF. This is VF. They have really chaotic ventricular activity. Those are both shockable. Our non-shockable rhythms are anyone? PEA and asystole, exactly. Those are non-shockable. So PEA is pulseless electrical activity. So there's electrical activity, but it's not causing a pulse. It used to be called mechanical dissociation. So electromechanical dissociation, so the electricity was not connected to the physical pumping of the heart. Okay? And so then we have reversible causes. You should know your reversible causes. I don't know whether or not they would come up. I know we were asked a lot in 3rd year. So, and I think the British use 4 H's and T's. We Americans like to use 5. I think maybe the British combine into thromboembolisms. And I don't think that they have the H+. By H+, I mean acidosis. Because H+ is a proton, or it means an acid. So what we're going to do is we're going to, first of all, any questions? Yeah. And any questions from anybody else?
Will the slides be online?
No, so we got the ECGs from an electrophysiologist back in the US, and he gave us permission to use these, but not to have them posted.
There is a handout though that we posted on the Facebook group, and yes, we'll see what we can do about publishing any of this, maybe the review slides and stuff, and if so, we'll post it on the Facebook group in the next couple of days. And are there any more questions?
And otherwise, we can maybe let you guys see some of these from
So,
the breakout groups. Some of these ECGs.
First of all, thanks for listening. It is a lot we've gone through. We hope you remember at least some of the stuff. And if you could just help us out with this question. And then we're going to tell you what is happening next. Code is 393805.
So we really, really appreciate you guys doing this. It does go in our portfolios. So for our future, as much as we enjoy, just the love of teaching, we are a bit selfish and would like some feedback for future interviews.
Just make sure to always go through each step when presenting an ECG, and you'll get logs.
And after this, we'll show the official, the way you should go through an ECG again. We had that on one of the initial slides. And then for those of you who are interested and completely bored, we do have several of our members standing by. So we have about 18 ECGs here to practice presenting in small groups. These go from anywhere from being quite easy to extraordinarily difficult, and that is for one main reason. We're trying to prove that no matter how difficult an ECG is, no matter what the diagnosis is, you can still pick up enough points using the method we taught you guys going through systematically to pass the station. So in some of these, I would not expect registrars to get the answer, but you guys will sail through the stations on these if you just go through the systematic steps. So This will help build your confidence, your promise, and will polish all of your presenting skills. So.
Please. A bit more. Yes, you know all the criteria, and it's now just about getting it into your head, seeing those ECGs, and it will really help if you stay for the group presentations. It won't take long, and we'll just practice your actual OSCE presenting skills. Anyone else? So, if you want to, leave us any comments or suggestions, personal recommendations. You wanna, feel free. And we're gonna let you all say anything you want to, and take a small break.
About 5 minutes, then we'll start
Maybe
with
next.
the small group presentations.
Shouldn't take long, and it's for your benefit. So.
Thank you very much. Emails and everything.
You do it now.
Oh, yeah, great. That's great. God, sorry.
Alright, pause it. So you just. Okay.